All right, here we go. This is diseases of the esophagus and stomach. Are we starting that? I can't remember. I prepped. I can't remember what this is about. We'll find out. It's week 3. It's Thursday. It's summer 2020. Here we go. It's GERD, so that title's not right. So we were talking about GERD last time, and I think we left off. We were just talking about the treatment for GERD. And the treatment is acid suppression therapy. That is the cornerstone for gastroesophageal reflux disease. If you have too much acid, turn it off. Don't let the stomach make so much acid. There are 3 weapons. PPIs, or proton pump inhibitors, are by far the most. That's the treatment. H2 blockers can be useful for nighttime acid. As a treatment in and of themselves, they're about 50% effective, if that. So they really don't work very good, and we'll see why. Prokinetic therapy was promising, but there are some serious cardiovascular problems that they increase the risk for those. So that leaves PPIs, and there's a little controversy with those as well. They may increase the chance for osteoporosis, although the jury's still out on that. Stanford, I think I talked about that before, but Stanford still is prescribing them, and there was a study that came out not too long ago that did show an increased risk, but that study was done on older people only, so they might have gotten it anyway. Anyway, dietary and lifestyle changes are also a very important part, and that's what you can help with. In fact, before they start getting, assuming they're not bleeding or anything, before they start getting on medication, it's your job to counsel them, and you can charge for consults like this. You can talk to them about what to do. As I told you, I got off PPIs myself just by understanding the mechanism of GERD, which is almost unheard of. So it's definitely doable, but I got one of these. You got to have a good quality Lazy Boy. Just have to be Lazy Boy, but it needs to be good. It's got a bad back, so I have to have support, and these are really supportive of your back. But yeah, some of the lifestyle changes, some of the rules, the laws, my laws. Don't go to bed until at least 3 to 4 hours after a meal. That's my is even worse than that. Mine's like 6 hours after a meal. Like I just ate at 5. I can't really go to bed. I didn't eat a huge meal, but I can't go to bed at 9. Now that would be, what would that be? That would be 4 hours away. Around 10 o'clock, I didn't eat that heavy. If I ate a big meal, like really get full, I wouldn't be able to go to bed till probably midnight. That's how slow my stomach empties because I'm old. Anyway, so yeah, so for normal people with GERD, young people with good processing stomach, you can't go to bed right after a meal, especially if you've drank alcohol, which will relax your lower esophageal sphincter. Okay, sleeping in a recliner, if you go out eat and you have to go out and eat, it's fine. Just sleep in a recliner. They're very comfortable. I can sleep just fine in one of those things. And then don't overeat, especially close. If you're going to pig out, the time to do that is a late lunch, like 2, 3 o'clock. That's the time where I still go and pig out. And usually I'm such a slow digester, I won't even be hungry. That'll be my dinner. And we already know right is wrong, especially when you go to bed. You should always try to sleep on your left side. Avoid the irritating foods, alcohol, spicy food, caffeine, chocolate, all the good stuff, right? Fatty foods, high protein foods, tomato sauce, that should be up higher on the list. Smoking has been related to GERD. They don't quite understand what the relationship is, but smokers have more trouble with GERD than non-smokers, so try to stop that. You can put your bed up on blocks to make an incline. Not good for if you have blood clotting problems, though, because then your blood won't come out of your feet. But it's not very effective. The research's not great on that. I tried it, and it really doesn't do anything other than drive my wife crazy. So she sends me to the recliner before we try that. And you can't get propped up high enough to do any good. There are foam inflatable wedges that will definitely help. But when we went to Hawaii, I had to take one of those. I was worried because the restaurants don't even open till 5 o'clock. So we're eating quite late. But I did fine. I had this little foam thing, and I'd go to sleep with it, and about 2 o'clock in the morning or so, I'd get rid of it and sleep normal. So they work really good. You could lose weight because the bigger your tummy is, the more pressure you have in your abdomen pushes up on the stomach and encourages it. Here's the exact one that I bought. It's really light. You just blow it up, and it worked great. It worked really good. This is another one that you can have at home. You can't travel this one. That's another option. For whatever reason, this one bothered my back a little. I had one just like it. And the little foam one worked better, or the little blow-up one worked better for me. Then there's over-the-counter meds. If you just had a hot, spicy Mexican food dinner that's really spicy, that tastes great, and you broke the rules, you should definitely, and my disclaimer, go check with your primary care physician because I'm not supposed to really talk about this kind of stuff. But you can definitely take some Tums if that's okay with your primary healthcare provider. I mean, they're over the counter, so you can definitely use them they're over the counter, so you can definitely use those just to kind of get ahead of the acid that and the irritating the hot spicy stuff is going to irritate your stomach. The acid neutral chewing gum never worked at all for me, but I thought I'd list it anyway. H2 blockers, as we said, histamine 2 blockers, histamine 2 receptors, AKAs for these things. This is an old treatment. Research shows about 50% effective, and those are even some of the manufacturer's study, so I think it's probably less than that. One good thing is they're safe, knock on wood. Never been any trouble with H2 blockers. There's no relation to osteoporosis with these things. They're not nearly as effective as proton pump inhibitors, not even close. The key players, I shouldn't say the H2 blockers aren't without danger, right? Because we had a big recall in October of 2019. Not because there's anything wrong with the H2 blocker, but it was mixed with something called NDMA, which is not a good thing to have in your body. And there's to this day, they're still recalled. They haven't straightened that out yet. So Tagamed, that used to be prescription. That's over the counter now. Pepsid AC. Those are the two big ones. Zantac was the big one. Ranitidine has been around forever. That used to be prescription for many years, and that went over the counter. So did Tagamed. These both went over the counter. They used to be full. You have to go to the doctor to get a prescription. Now that's all that's left is Tagamed. Here's the NDMA. So there's cancer concerns about this. It was very popular. And the older it sat on your shelf, the higher the carcinogenic level seemed to be found in these things. So these are definitely don't take Zantac, right? If mom or dad has it laying around in their cupboards, throw it out. Don't take it. So we'll see the problem because I took those slides out last quarter. I'm going to make you, because you've already had GI physiology. So I'm going to let you can watch my YouTube video if you need a refresher. I'm going to assume you know about the physiology of the stomach, and including the hormones and how things work. But if you'll remember the parietal cell, which is in the fundic gland, right? In the fundic region of the stomach lives the fundic glands. In the fundic glands lives the hipsters. And we'll explain that when I come to it. But in the fundic gland live parietal cells and chief cells. Those are the big ones. And D cells and, not G cells though. But anyway, the histamine, there are three types of receptors on parietal cells. Parietal cells secrete hydrochloric acid, right? There's three types of receptors. There's H2 blockers, there is acetylcholine receptor, and there is a gastrin receptor. Anybody see a problem with blocking just the H2 receptor? It doesn't work. So what if you block histamine? I mean, it's a powerful receptor. It's a powerful stimulator. In fact, it's the most powerful stimulator of hydrochloric acid. But what about the gastrin receptor? What about the acetylcholine, which is the first receptor to get stimulated? There's no blocking of this. So, I mean, I don't want to say it's bogus, but it's like, what's the point? That's probably why it doesn't work so good. See the problem? Yep, I just talked about the problem. Okay. Prokinetics were a great idea. They were designed to increase the tone of the lower esophageal sphincter, and they do increase the tone and increase the peristalsis of the esophagus and stomach. So mix them with a proton pump inhibitor, and you got some very happy people. And that sounds great, but there's a huge problem. The best ones are now banned because the cardiovascular heart attack and stroke dramatically went up, statistically significantly went up with these medications. So they're out. PPIs, that's the number one treatment, hands down for GERD. It's about 80% effective. We'll expand on it as we go through this program. I want you to know these. You need to know these because they're going to be on your patient intake forms. Prilosec is over the counter. Used to be prescription. That is now it's over the counter. Prevacid is, I think that's always been over the counter. Protonix that's the one that worked the best for me. That's the one I was on for years, and that worked great. Prilosec didn't work at all for me. Protonix worked great, but it is prescription, so you're going to need your primary doc to write a script for that. But again, there's a chance that could increase the chance for osteoporosis. I think I took all the research out of there. You'll see there's just so much material I have to get through, so I'm trying to take stuff out here and there. PPIs, they will be absorbed right through the stomach wall and sink immediately into the parietal cell. And remember, again, parietal cells secrete acid and intrinsic factor. Within the parietal cell, they bind to two things. The very important enzyme that's part of the hydrogen ion maker, carbonic anhydrase. All right, sorry, I think I lost you. Our internet must have dropped out. Sorry about that. We'll have to go with YouTube. But carbonic anhydrase is the key enzyme for making hydrogen. Hydrogen and potassium ATPase pumps, they bind straight up to those pumps and knock them out. All right, so here's a parietal cell. So you should know this, right? You already know this, but I will test you on this thing. Here is a parietal cell which lives in a fundic gland, which lives in the fundic region of the stomach. Where's the fundic region of the stomach? That's the fundus and the body of the stomach. We talked about that. Carbonic anhydrase takes good old water and CO2 and makes carbonic acid. Carbonic acid splits apart by itself. It doesn't need any enzyme. And it forms bicarbonate, which is shot out into the interstitium. You've probably learned about the alkali tide that goes along with this, which I'm not going to explain. But the lumen of the gastric pit is over here. So the hydrogen ion is shot out into, basically it'll get into the lumen of the stomach via this proton pump. Chloride has its own channel that's pretty straightforward. But yeah, so PPIs will bind to carbonic anhydrase, knock it out. And yeah, so that is pretty cool. They also bind to receptors on the proton pump and screw that up. We won't go into the mechanism. So it's a double system. So that is pretty awesome. Okay, so no hydrochloric acid is made. And yeah, now the stomach, the proton pumps in the parietal cells in the stomach is wise. It knows that something is working against it, and it will generate new proton pumps to take the place. But by the time they're generated and made, it's too late. The stomach's gone, and the stimulus to make the acid is gone. So yeah, it doesn't work. But that has something to do with trying to come off PPIs when you have more, your stomach used to making extra proton pumps, and you try to come off, and now you don't have PPI. Some believe there's a rebound effect, which makes it so difficult. I really didn't have that much trouble coming off them, though, once I figured out how to fight the problem. There's no proton pump inhibitors. There's no problem with NDMA contamination. But make sure the patient understands that it takes 2 to 3 weeks for that to get working. Okay, just trying to see what happened to if it was my internet or your school internet that lost it. And nope, it's not my internet, so something happened with the school internet that dropped this recording. Because mine's good, 113 megabits per second. This Charter or Spectrum, when it's working, it just flies. But God, I've had nothing but trouble with this. But maybe they finally fixed it. They were supposed to fix it last week. But anyway, so where were we? Yeah, it takes 2 to 3 weeks to work. Here's a classic study from the New England Journal of Medicine, and it was the study was about the success of PPIs. So this is the percentage of people who were 100% pain-free after the use of 1 year of PPIs, and you can see they did different groups of patients. One only got, these are H2 blockers. One got only Prokinetics. The H2 blocker and Prokinetics did pretty good. The PPIs did fantastic. If you added a Prokinetic to a PPI, they did even better. So that was the ultimate there. Almost 90% of people were completely cured of their GERD after this, which is really good. But we don't have this anymore because of the dangers. Here's another meta-analysis, the Wren meta-analysis. This is more recent. This is 2014 of 2,400 patients, and 84% of them after the year of being on PPIs got really good relief. So it pretty much, even a little higher than this study showed, 13% didn't get any relief. This was with erosive esophagitis. So to get into the study, you had to have visible damage to the esophagus. Interestingly, though, the patients with NERD, remember I said that's a tough group, the NERD patients, only 55% of them got good relief. So NERD might be a little psychological stuff, a little anxiety, a little overactivity of the sympathetic nervous system going on. It's a tough group of patients to treat. Why not 100% effective? One of the theories is nocturnal acid. Some people release acid at night, and we don't quite understand the stimuli. It must be sympathetic and ACH, acetylcholine, but some people do. And some people get good relief if they add a H2 blocker before they go to bed. Or even I've heard people just using Tums before they go to bed. If there is any acid, because you take your H2 or you take your PPI in the morning, and that's at night, 3, 4, 2, 3 in the morning or so. That's where the blood serum concentrations of it are going to be the lowest. So you could also double the dose, but then we start to worry about the osteoporosis thing. There are some other differential diagnoses, other causes of GERD symptoms. Medication, so you could get an upset stomach from medication, from H. pylori. Any of the gastritis or gastropathies could do it. Esophagitis can be inflammation of the esophagus. Eosinophilic esophagitis in particular can do it. It's pretty rare, but it is out there. It's not as rare as Marfan syndrome. Certain amounts or certain autoimmune diseases like pemphigus vulgaris and bullous pemphigoid. We'll talk about that in 7th quarter. Those are the most common blistering diseases. Some people have trouble with, they start out as hives and then they turn into flat out blistering diseases where the layers of the skin rip apart. Eosinophilic, there it is, eosinophilic esophagitis. Heart disease, maybe you have angina, maybe you have a narrowed coronary artery and you're getting that confused with GERD symptoms. Or maybe it's just an infection of the stomach or esophagus with HP. I said that already. This is bullous pemphigoid, BP. We'll go over this more in dermatology. but it's an autoimmune attack against BP230 protein, which is a member of the hemidesmosome. Remember, hemidesmosomes, they lock the skin to the dermis, and it's attack against them, and it's not a good thing to have. Let's see, other causes of GERD-like symptoms: chest wall pain. One of the gastropathies could do it, we said already. Peptic ulcer disease, hypersensitive esophagitis. Your esophagus is just super sensitive. Psychological conditions, as we said, depression, anxiety could add in there, rumination, people who are worrywarts, they're just always focused on, probably have a lot of more stomach problems with all this COVID going on, because of a certain chunk of people have these type of problems. What if you fail PPI therapy? You've tried it, it just doesn't work. What's next? The ultimate is called a fundoplication. And it's a big surgery, so you want to make sure, if your patient is contemplating this surgery, make sure they have tried everything. They truly have to be disabled, because the chances of them making this too tight and causing dysphagia is a problem. So let's talk about it. It's a surgical procedure. It fixes the lack of tone. What they basically do is take the fundus, they disconnect the stomach's moorings, they wrap it around, and they use the fundus of the stomach to make kind of a makeshift new lower esophageal sphincter. And that's basically what they do. And here's a nice picture of it, where nice and neat. There's the diaphragm, we're looking up. Thoracic cavity would be up here. And they've taken the fundus, they've pulled it around the esophagus, and they've sewed it. Okay, what are the goals? So that while they're in there, let's go back here. While they're in there, they can also put some stitches in here to tighten up that esophageal hiatus. They can try to beef up the right crust as well while they're down there. And yeah, so that's it. And the problem with it is a certain percentage, anywhere from under 1%, I've seen up to 10%, get dysphagia. And they can't swallow because they made it too tight. But all in all, patient satisfaction is halfway decent with this procedure. Okay, pre-cancer, Barrett's esophagus, big board one right here, Barrett's esophagus. We should talk about a little Cooperstein pathology. So hyperplasia, remember all this stuff? Hyperplasia, what does that mean? Hyperplasia means you have a perfect example is a callus on your foot. You got some new shoes and they're kind of tight. Or you started playing the guitar and you got calluses, like I have calluses on my fingers like crazy. A chronic stress causes cells to increase in proliferation. So your body feels the stress, and maybe you've even got blisters before, whatever. Your body says, okay, we're just going to make new native cells, and that's going to help with the problem. And so hyperplasia means you have more cells than you normally have, and they're the same cell type though. The tissue has not changed. Okay? Hyperplasia can go to the next step where tissue actually changes. So if hyperplasia doesn't get the job done, or if it's a different type of irritation, like chemical irritation, your native tissue might become metaplastic and jump right into metaplastic condition. So metaplasia means that the chronic stress has the body, in response to a chronic stress like cigarette smoke, has changed the tissue from its native type into something more rugged, like stratified squamous. It's got more layers in it. It's better able to understand or kind of withstand the environment. All right, this visible change, that's called metaplasia. It's not a new number of cells though. The cell numbers are still well, that's not exactly true though, depending on what type of metaplasia. But it's not, the native tissue just doesn't make more cells like a callus. the cell type changes. Typically, metaplasia means that the simple columnar cells morph into stratified squamous. That's the most common type of metaplasia. And so in the way, yeah, there is more cells because simple columnar, we know what those look like, right? They're just little rectangular cells. But if they keep getting bombed with acid and the acid is ripping things up, the body will turn them into stratified squamous, like your skin. It's not full like a full 4 or 5 layer though. It's a kind of a modified, but nevertheless, it's stratified squamous cells. Okay, so that's the typical type of metaplasia. Okay, what are some stressors that can induce metaplasia? Cigarette smoke, air pollution, even NSAIDs and aspirin, stomach acid, the HPV virus. They can all stress the body into changing the tissue type. Smoking's effect on the esophagus is not on the esophagus, that should be on the tracheobronchial tree, right? Yeah, I gotta fix that one. 39. How can I remember 39? Larry Zonka's number. I used to memorize football players' number. Look him up. He's a tank, a tremendous fullback for the Dolphins. Larry Zonka was 49, so I'll remember to change that. So smoking's effect on the trachea or tracheobronchial tree. Cigarette smoke particles, they damage the normal tissue of the tracheobronchial tree, which is pseudostratified ciliated columnar epithelium. Those cilia are really important for clearing junk out of your throat. Wake up in the morning, and forest fires going on, or you're out at a smoky bar, or whatever in the morning. That those cilia have swept all the crud, including bacteria, out of your tracheobronchial tree into your larynx, and you can swallow it or spit it out at that point. But with chronic irritation, that cigarette smoke irritates them to the point that the body says, nope, that's it, we're pulling you guys out. We're going to move a tissue stronger and better able to withstand cigarette smoke. And that would be simple squamous epithelium. Okay, so sometimes people call that squamous metaplasia, is the smoking type of condition. Okay, remember that stuff? What's the sequelae of metaplasia or metaplastic tissue? Well, we just said, without cilia, there goes your ability to sweep that junk out of your tracheobronchial tree. Specifically, you wreck the mucus escalator, or Rubin's, which is a board book, says you've impaired ciliary clearance because you don't have any cilia anymore. You just have cells that are flat and protective. Right? And mucus production could decrease. Here's a classic histology slide. And this is pseudostratified. Remember pseudostratified? It looks like there's more than one layer, but they all touch the basement membrane. See, that one's touching, that one's touching, that one's touching here. So this is a single layer of cells. And it's ciliated. So the mucus glands of the tracheobronchial tree produce two types of mucus. They produce a thin and a thick mucus. The thin mucus layer is called the Saal layer. And it's got to be thin because these little hairs have to beat. And these things are moving and they're pushing this way. Above that is the gel layer, which is very thick and so sticky it sticks to the Saal layer. And the bugs and the debris, cigarette smokes, air pollution there, whatever, this stuff is constantly being kind of jettisoned or pushed up to the larynx, where you can decide what to do with it, spit it out or swallow it. Cystic fibrosis, what happens? Quick, I shouldn't do this because we have such a long lecture. Cystic fibrosis, there's no Saal layer. Everything's gel, and this thing is paralyzed. So nothing, it still catches bugs, but it's so thick that the cilia can't work. And then these bugs breed like little bunny rabbits, and pretty soon the bugs are wild and the bugs are infecting here, and you have a wicked, they usually die of pneumonia in the 30s because of this. All right, so here's someone with metaplasia. There's the native tissue the ciliated pseudostratified columnar epithelium, and here the tissue said, that's it, we're going to simple squamous, right? And you can see it right here. I won't test you on that. That brings back Dr. Doe days. Further tissue exchange beyond metaplasia. So if you keep smoking, even after you have a horrible smoker's cough and you just keep smoking, your cells may get upset, and some of them might, well, it's not that they get upset. The metaplastic cells themselves may become damaged. The cigarette smoke particles may be carried into the nucleus of these cells. Some genes may be turned on that are not supposed to be turned on, and now things can go haywire. Do we still say that word? My dad used to say that word, haywire. That's a new word for you, haywire. That's like cuckoo, or they go crazy. And if apoptosis gets turned off in the cell, it becomes immortal. And so now you got an immortal cell, and maybe that's no big deal, but maybe one's mutated, and it's a super fast divider, and it's immortal. That's cancer. It divides and it divides and divides, and you got like a mass growing, and that's cancer. So once they become mutated, they are said to become dysplastic. So dysplastic means they're mutated. They also live too long, and there's different degrees of dysplastic tissue. So the first degree means there's not too many of these mutated cells. There's actually still, if you stop smoking, it still might revert, and maybe might even go back to ciliated epithelium again. I don't think that happens too often, but some people, at least the research says it can happen. But as the dysplasia gets worse and worse, though, if you got this tumor, all these cells starting to build up, I don't want to take too much time building a tumor here. There's a basement membrane down here. We've got these mutated cells growing like crazy, and you got a tumor. Some of these guys may start breaking loose. They're desmosomes, they break loose. And some of these guys may break loose from the basement membrane and go down. And that's in trouble because we got the blood vessels underneath here, right? And they get into the blood vessels or the lymph vessels, metastasis. So not good. A low-grade dysplasia still is attached to the basement membrane. It's still considered a precancerous condition. Does not involve the entire tissue, though. Still could fix the problem in this low grade. And then there's a middle grade. We'll just jump right to high grade. That means that most of the cells are mutated. They've taken over the tissue. They're not attached to the basement membrane, and but none of them have not moved down to where the blood vessels are. So this is also called a cancer in situ. And there's different authors have different opinions on this. So this is Rubin's and Robbins, which are the board book opinions. Once severely dysplastic, the cells break loose, and then you don't call it dysplastic. Once it invades the dermis, if it's skin cancer, or the deep tissue, the submucosal layer, if we're talking about the esophagus, you got yourself a full-blown cancer. And then once it spreads, if it shows up in your liver, now you have metastatic disease. The cancer's metastasized. Super high yield board stuff, the Barrett's. I think if I had some of you in first quarter, I don't know if I had you in second quarter, would be where I showed you the Barrett's esophagus, showed you what it looked like. But metaplasia or dysplasia, if the esophagus becomes metaplastic or dysplastic, flat out dysplastic, that's considered precancer. Even metaplasia is considered precancer. I mean, it's really pre-cancer. You're 2 steps away from it. Dysplasia is 1 step away from cancer. So if you want to get technical, metaplasia is pre-cancer and dysplasia is precancer, but they're not. The boards are not going to say that. Metaplasia or dysplasia with regard to Barrett's esophagus is precancerous because metaplastic esophagus turns into dysplastic esophagus really, really quickly. What's the cause? We know the cause. Barrett's esophagus it's from overbathing the esophagus with gastric juices. And a tissue metamorphosis has occurred, a metaplasia has occurred, because it can't, the tissue can't stand it anymore. Remember, the tissue is stomach tissue up to the Z line, and then above the Z line, it's a stratified squamous tissue. So what happens is a better tissue that's better able, and this is kind of weird to me, but for whatever reason, because I don't think this stomach tissue would be the best, but that's not the one that becomes cancerous. You could have stomach tissue just continue upward, but that's not the one we worry about. If it becomes intestinalized, if you have flat out enterocytes, simple columnar intestine, like from the duodenum or from the jejunum, and there's goblet cells, that's not a good sign. Those typically go on to cancer, and they have to be watched very closely. We know this already. What allows the acid to burp up? We've already talked about that. Hiatal hernia could do it. Loose lower esophageal sphincter. Hypoactive peristalsis of the esophagus. So if you do burp up acid, you can't clear the acid. So that's weird. And there are conditions where you just flat out oversecrete acid, which we will talk about. Zoller-Ellison ZE syndrome is the big one. In genetics, some people just secrete too much. Stress, sympathetics may be turned on. That releases acetylcholine from the enteric nervous system, and it turns on the proton pumps because it has a binding site for acetylcholine. The proton pump, or not the proton, but the parietal cell does. What are the symptoms of a Barrett's esophagus? They're just GERD symptoms. The heartburn, chronic heartburn, peristernal burning pain, retrosternal burning pain. Some people feel it down in their epigastric region, so they might get GERD confused with dyspepsia. Some people may not. This is the scary one. Some people may not have any symptoms at all, and that one is dangerous because your tissue can become metaplastic, and you have no idea, and you end up with esophageal cancer. You're like, how can I have esophageal cancer? I don't have GERD. You don't need to. Some people don't feel it probably because they just don't have a lot of nerve fiber there. Why some people feel pain, other people don't feel much pain from a disc herniation. They don't have nerves to feel that type of pain. They're lucky with a disc herniation. Not so lucky with an esophagus. How do you officially make the diagnosis of Barrett's esophagus? Well, you got to stick an endoscope down there and take a look. And then when you're down there, you got to take some samples of the tissue to see what the cells look like. And then you got to give the tissue to the pathologist, and the pathologist is going to make the call. It's an important job pathologists have. So here is well, you know what this is, right? Is this normal or not normal? That's normal. There's the gastric fold. So this is the lower esophageal sphincter. We're inside the esophagus with an endoscope. These are the so-called Z line is great, but that may not always be the case. So this is an important slide. The difference between, there's two types of Barrett's esophagus. There's long segment and short segment Barrett's esophagus. The short segment is the one that's typical. Lower esophageal sphincter is way down here. That's where these little gastric folds are. So this one has went up 3 millimeters, but no more than 3 millimeters. If it doesn't go more than 3 centimeters, not millimeters, if it doesn't go more than 3 centimeters, it's called short segment Barrett's esophagus. That's a better one to have. It has less of a chance to become cancerous or precancerous. It has less of a chance. You still have to watch it, but it's not as bad. If it goes more than 3 centimeters, that's called long segment Barrett's esophagus. That one ain't good. That chances for that one to become cancerous is quite a bit higher. What do you think of this? There's the lower esophageal sphincter see the folds way down there? Oh, that's way more than 3 centimeters. So this is a long segment Barrett's esophagus, and this patient has to be watched like a hawk. If there is histological evidence of tissue metaplasia, or even worse, dysplasia, they have a Barrett's esophagus. Specifically, though, it has to be, people don't understand this, it has to be intestinal, simple columnar epithelial, and there has to be goblet cells. That's the one that they worry about. Some people say there's glandular. That's not a good thing. I should probably get rid of that. Other types of metaplasia. So these are the better ones to have. You could have metaplasia, and the doc looks and says, "Oh my God, you got a long Barrett's esophagus. That's not good." But let's see what the pathologist says. Maybe that tissue is not intestinal tissue. Maybe it hasn't intestinalized. Maybe it's just a continuation of the stomach, the cardiac tissue. That's awesome. Well, it's not awesome. It's still not great. It could still become cancerous. But if cardiac or even fundic tissue, if stomach tissue shows up above the Z line, then it's better. The chances of it turning cancerous are not made. In fact, they don't even count it as Barrett's esophagus. So to have Barrett's esophagus, you have to be intestinalized, meaning there has to be simple columnar tissue with goblet cells. The stomach, simple columnar, right? But there's no goblet cells. Those stomach cells are called mucose cells because they all secrete mucus. That's not true of the esophageal or of the intestinal cells. They need goblet cells to do that. Okay, we don't need to worry about that. Dr. Doday's bad sign. If metaplasia morphs into dysplastic tissue, it's a bad sign that it's going to become cancerous. It's usually an adenocarcinoma. We'll look at that here in a second. But if it morphs from metaplasia and it moves into dysplasia on your 6-month follow-up, there's a 40-fold chance that you're headed for esophageal cancer, which is a horrible diagnosis. What do you think of this? Long segments Barrett's esophagus. So, the histological exam showed it was intestinalized. So there's goblet cells and it had simple columnar tissue in there. Epidemiology. This is a middle-aged disease and an older people disease. Very, very rare in children and people your age. The average age is about 55. Caucasians seem to be affected more. Blacks and Asians not affected as much. Prevalence is quite difficult because a lot of people have Barrett's esophagus and they're walking around right now and they have no idea they have Barrett's esophagus. And so keep that in mind. A study of 961 asymptomatic people who came in for GERD. That doesn't make sense, does it? That should be symptomatic. GERD-P. So a study, that should be GERD. I need a 62. How can I remember that number? Let's see. My football number was 63, so I can remember that. See how I use those old memories. You never forget when you're your age the things you remember when you're your age, you remember forever. As you get older, it's harder to get things in your deep memory. I digress. So that should be 961 middle-aged people who came in for GERD for endoscopy. Surprisingly, 6.8% of them had a Barrett's esophagus already. So it's definitely out there. Some studies have shown people with chronic GERD symptoms, they finally get in to have an endoscopy. It's up to 15%. The chances for Barrett's esophagus becoming cancerous increases 7-fold in the past several decades. Why in the heck is it going up? So the theory is, this question, I believe this is on your test, if I remember right. This is important. Why is the prevalence of GERD and Barrett's esophagus going up? Right? Because if Barrett's esophagus is up, GERD must be up. The bug, HP. This thing is a menace. But if you eradicate H. pylori, it actually increases your acid and increases GERD. People are also getting more obese, which increases intra-abdominal pressure, and then it squeezes the stomach to push the acid up. How about some risk factors for Barrett's esophagus? People have had a long history of stomach problems and GERD problems. They have an increased chance. People with large hiatal hernias, uh, they're going to have acid. If they feel it or not, who knows? But if you have a big hiatal hernia, the worry is it could become cancerous. You could develop GERD. People who have low lower esophageal sphincter pressure on mammometry, they're going to have GERD whether they feel it or not. These are all, we know these already. Decreased esophageal motility, when they burp up, they can't clear the acid and it irritates the tissue down there. And maybe they're just increased sensitivity, esophageal sensitivity reflux, whereas people, decreased sensitivity, they don't feel it. And that's the problem. And obesity, I could take that one out because we just talked about that. Obesity versus Barrett's esophagus, we talked about this. Increased obesity increases intra-abdominal pressure, squeezes the stomach more, and encourages the stomach acids to go up into the chest. Everything I just said. Central obesity is worse. Homer Simpson belly is central obesity. Those people have increased chance for Barrett's esophagus. How about PPIs in Barrett's esophagus? So about 30% of Barrett's esophagus patients actually do pretty good with PPIs, but the problem is they still have acid reflux, so they get faked out. So if you have Barrett's esophagus, you're going to have to get checked fairly often, probably throughout your life, right? Because you don't want to, you'll see the cancer is about 15% 5-year survival. It's a horrible cancer. So they have to be monitored. What about the management of Barrett's esophagus? Well, it's like GERD. It's the same rules for GERD, right? And they should be using PPIs, even if they're, or at least antacids, TUMS, even if they're not symptomatic. If they're asymptomatic, because if you've had Barrett's esophagus, you're probably still getting acid reflux. And we know the GERD rules, the regular endoscopic reevaluation. So if you just were diagnosed with metaplasia, you should every year have a repeat of that study to make sure it doesn't turn dysplastic. If you were diagnosed with dysplasia, low grade, every 6 months you need to repeat that study to make sure it doesn't go to high grade dysplasia. If you're high grade dysplasia, they're going to take it out. But if you choose not to, then you're going to have every 3 months. You have to be, and it's not fun having these procedures. I've had a bunch of these things. Okay, carcinoma, esophageal carcinoma, as I said, deadly. I missed it. I said 15. The survival rate for 5 years with good treatment, the survival rate is 17%. It's a horrible, horrible type of cancer. Kills more than 400,000 people per year by itself. I'm trying to think, COVID-19, how many people has that killed? I don't think it's killed that many. It's the 8th most common cause of death worldwide. 16,000 new cases are diagnosed each year. The most common upper gastrointestinal tumor in the world is cancer. Not so much in developed countries. What are the signs of the cancer? Well, no, it's not GERD. They may not have GERD. The sign that the cancer has developed is solid food dysphagia. The tumor is so raw when they eat solid food, they can't stand it. So they have to switch to soft food. Now remember, this is worldwide. I mean, at this point, we would all go to the gastrointestinal doc and say, hey, something's hurting, I can't swallow. But in some parts of the world, there's no doc to go to, or they don't have money to do. So they just say, well, I'll just eat softer food. I'll eat bread and eggs and nothing meaty. And then they do good for 3 to 6 months, and now they can't even do that because it's hurting. So they go to a liquid diet. And then even the liquid hurts. By the time they finally go in to see the doc and they stick a scope down there, it's too late. They're gone. So that's a bad progression there. May or may not be associated with GERD symptoms. Look at this number. Right? You even put your emoji in here. That's called an emoji, I've learned. And he's in shock, or maybe it's a she, he or she. It could be either. 45% of the patients with gastroesophageal or with esophageal adenocarcinoma, they had no GERD symptoms or very, very infrequent GERD symptoms. That's kind of a scary number to me. So almost half of them had no symptoms. So it's kind of like a silent killer in a way it can be. Late stages in the disease, it may show up as the supraclavicular nodes. This one, usually the right. Gastric carcinoma usually gets the left one, Virchow's node, or Trousier's node, it's called sometimes. But the right supraclavicular node is often blown up in this one with esophageal cancer. Okay, there's the left Virchow's node. That's a patient with stomach cancer there, actually. Making the diagnosis, well, you do an endoscopic evaluation and you take histological samples of it, and you give it to the pathologist to see what stage it's in. You order a CT scan next to see where it's spread, a CT of the entire body to see as it went to the brain. Is it in the lungs? Is it in the spine? Is it in the liver? Better, if we're in the Bay Area, we have something called a PET scan. I think most of the in the developed countries have PET scans. That's the one you want and not a CT. Sensitivity and specificity are much higher in a PET scan, so that's what you want, especially the sensitivity. It's positive emission tomography, and you swallow a radioactive tracer which has an affinity for cancer, dysplastic cancer cells. And it sticks to these cells, and then you take a CT, and it shows up. It lights up like a light bulb. You also have to do lymph node biopsies adjacent to the tumor, wherever they may be. Here's a PET scan on a 55-year-old smoker. 6 months ago, they started having dysphagia, and they've a tumor here. So they had to do a PET scan to see if it spread, and unfortunately, there it is here, and it spread here, and it's not good. That's stage 4 cancer, right when it spread. It's metastatic disease. There are two types of cancer. The most two common types are the adenocarcinoma, which is most common in developed nations. And these are the ones that are associated with Barrett's esophagus. So there's lots of slides here. Barrett's esophagus usually turns into adenocarcinoma. Smokers, on the other hand, don't get adenocarcinoma. They get squamous cell carcinoma, which we're not going to go any further than that. But make sure this is a good slide for boards and all sorts of stuff. Adenocarcinoma for Barrett's esophagus. All right, switch gear. Mallory-Weiss tear is a rip of the esophagus. So you rip the distal esophagus, usually from throwing up. Bulimics have this type of thing. Drunks, alcoholics have this type of thing. We're throwing up all the time. So it's a tear in the distal esophagus, usually near the gastroesophageal junction. It results in several degrees of bleeding. And the blood in the stomach, by the way, you get blood in your stomach, you're going to get nauseated and throw that blood up. Your stomach does not like blood in it. And so it's typically caused from people who vomit, as we said, and that's bulimics and alcoholics. There's type of, let me see, what did I do there? Hematemesis. Hematemesis, this is kind of a weird slide. I need to fix this. Hematemesis is throwing up of blood. And the blood that comes out, it's going to be two kinds of blood. It's either going to be bright red blood, which means there's probably a lot. It's more concerning to see bright red blood. That means there's a lot of it in your stomach. But it might look like coffee grounds and be brown. These are the two types of hematemesis here. That usually means that it's a smaller amount of blood and it's been sitting in your stomach, and the stomach's been digesting it and turning it brown. Another important concept, upper GI bleed. We've heard this on TV, right? Versus a lower GI bleed. What does that even mean? Well, go back to our anatomy. Do you remember the duodenal jejunal flexure? So the ascending part of the duodenum meets the jejunum at a little bend there. That's also where it dives back in the peritoneum. Remember that most of the duodenum is extraperitoneal. It's outside the peritoneum. But the jejunum and the very end of the duodenum dive back into the peritoneum. And there's a ligament right there that holds that little bend, and that's called the ligament of Treitz. And that ligament, that duodenal jejunal flexure, or the ligament of Treitz, that's the demarcation spot. Anything upstream, like your duodenum in your stomach, those are considered upper GI bleeds in your esophagus. Anything downstream from the duodenal jejunal flexure is a lower GI bleed. So that would be your jejunum, your ileum, your large intestine, your rectum. What did I forget? No, that's right. Well, I was going to say cecum. That's lower GI bleed too, right? So remember this from anatomy. There's a ligament of Treitz. It's a double ligament. It's connected into here, into the celiac trunk. It also connects into our friend, the right crus. The right crus is quite an amazing thing. Remember, it lassos, beefs up the lower esophageal sphincter. Anything upstream, yep, everything I said. Did I make a picture of that? I guess I didn't. I thought I did. But yeah, so this is upper GI. There's the demarcation zone right there. Anything upstream, upper GI. Anything downstream, lower GI bleed. Free blood degradation. The longer blood sits in the stomach, we said it breaks down into a darker material. Specifically, the hemoglobin is broken down into something called hematin. And that makes it look like coffee grounds, or it looks black like tar if you defecate it. Okay, fresh blood is always red, whether it comes out the mouth or the anus. That means it's fresh blood. Hemoptysis is the coughing up of pink, frothy like blood. It's got air mixed in with it, so that's not a bleed per se. A pink frothy sputum, that's not like esophageal bleed. That means that something is forcing blood fluid into the, not the interstitium, but into the alveoli. Because the alveoli is just like the interstitium. Capillaries dump blood fluid, or they can dump blood fluid if the pressure is too high. If the pressure is too high, if the pulmonary pressure is really high from a beaver dam, let's say in the heart is failing, and you have a long train of blood waiting to get into the heart and the pressure is increasing, some of that blood and some of the serum can get drained into the alveoli, and you can start coughing that stuff up, and you'll get a kind of a pink frothy sputum, and that's hemoptysis. Hemoptysis. Hematemesis is vomiting. Emesis means vomit, blood. Hematemesis is vomiting blood. And yeah, so it usually indicates an upper GI bleed. So hematemesis goes with upper GI bleed. And then there's the colors, as I said before. If it's a red color, that's more worrisome. You're bleeding like crazy. If it's a brown color, you're probably leaking a little blood, but it's probably not as bad because the stomach acid has dissolved the blood. There is bloody vomit in someone with an upper GI bleed from a PUD, from peptic ulcer disease. Coffee ground vomitus, we already talked about that. I don't know why this slide is in here again. But it comes from the esophagus, or maybe the duodenum, maybe you have a loose pyloric sphincter and it's leaked up there. But usually from the esophagus, it's drained into the stomach, or it's a stomach ulcer. But yeah, there's real coffee ground vomitus right there. This seems like a long lecture, longer than normal, doesn't it? I think we kind of back off on these as we go. I'm going to try to stay with my same slides though. Hematochezia is another word. This is the passage of fresh red blood through the anus. Hematochezia, make sure you know this stuff, usually indicates a lower GI bleed, usually from diverticulum of the colon. Could be from hemorrhoids. That's really common as well. Could be inflammatory bowel disease, especially ulcerative colitis. You can bleed with that one. Maybe it's you had a big bowel movement and you ripped part of the anus and you're bleeding from that. That's possible, especially in kids. And if you have a really bad upper GI bleed, that would be very concerning. You'd probably go into hypovolemic shock, but it's if it could be bright red. It's unlikely. It's going to be a lower GI bleed. So he's a little baby who had some pretty bright red blood coming out from a or from a colon problem. Melena is the opposite. That's like coffee ground vomitus. That usually comes from an upper GI bleed in the intestines, and that blood has went all the way through the intestines and been digested. So it's like coffee ground vomitus, but it's coming out your other orifice down there, your anus. Okay, so hemoglobin was turned into hematin, and there is a melenic stool. What it looks like? It looks like tar, and that's from a person who had an ulcer, duodenal, or no, what did they have? I forget what they had. I can't see my comments down below are blocked for me, so I can't. Usually I tell the story of where it came from. Occult blood is another one. When you get older, everybody should have an occult blood test every year. That colon cancer is notorious for leaking a little bit of blood. But the blood is so small you can't see it with your eyes, yet it's in your stool. So you get this fecal occult blood test and you check it. You scoop a little poop up and put it in a little dish and send it off to the lab. Or nowadays, there's even some you can test it right at home. If it's positive, you need to have a colonoscopy to find out what the deal is. What are some of the risk factors for this ripping of the esophagus, this Mallory-Weiss tear? Too much alcohol, especially strong alcohol. It's the number one risk factor is too much alcohol. People who are bulimics, especially with connective tissue, they didn't. Morrison didn't put that in there, but people with connective tissue, they're not as strong as other people, so that would make things worse. People on anticoagulation therapy, zillions of people are on anticoagulation therapy, older people, the baby boomers, and they're at risk for bleeding. All it takes is a little cut, and if you're if you're on blood thinners, you're going to bleed like crazy. Hiatal hernia, that will also increase it because you're probably going to have GERD and a ripped up esophagus from the hiatal hernia. And some people come in bleeding in the ER, and they don't have any of these. And they idiopathic. They don't know why. I bet you anything it's underlying connective tissue or a multi-connective tissue disorder. That's yet to be diagnosed on that. Can you get here's a good question. Can you get peritonitis from a Mallory-Weiss tear? Esophagus. That's not in the peritoneal cavity, is it? Yes, it is. Mallory-Weiss tear usually happens right down at the distal, right where the lower esophageal sphincter is. Really, right where the gastroesophageal junction is where it happens, and that's intraperitoneal. Remember, the esophageal, the abdominal esophagus is an intraperitoneal organ, so you sure could have it. And so you could get peritonitis and croak from that one. There's a Mallory-Weiss tear right there, cartoon of it. There's a real big one. Very, very painful. Let's see, 10% of all people with hematemesis end up having a Mallory-Weiss tear as the cause. So that's a pretty good number. Mortality rates, even with good treatment, still 3%. I mean, bleeding down there can be, you can bleed in, you can bleed out. You can go into hypovolemic shock, cannot realize the blood's going into the stomach, especially if it's bleeding like crazy, which leads us to another cause of people going into hypovolemic shock. The last topic of the day, I almost took these slides. I probably should have took them out because we're like, without all our breaks and stuff, this is, there's so much material. I got to give you material. I don't have to give you material, but I mean, No. Let's finish. Stay on point. Varicose veins, we know what those are. How about varicose veins of the esophagus? Yeah, esophageal varicosities. That's what this is. So, yeah, it's the distal esophagus has a venous system on the inside and a venous system on the outside. So you can get varicose veins and swell those guys up. This, think liver disease. So about seven. The prevalence of liver disease is not super common. It's 0.07% of the population. But 50% of people with liver disease will actually develop esophageal varicosities. 50%, that's a big number. And this one can be fatal. What's the sequelae of this? Bleeding, a medical emergency. You can go into hypovolemic shock because of this. On average, 20% mortality rate. It's just like pulmonary embolisms. 20% mortality rate for the first bleeding event. So yeah, it's not even higher for people who are on anticoagulants. You bleed even more. So not good. Here's a normal esophagus. Oh wow, look at that. Crazy varicose veins, right? You pop one of those things, you're in trouble. You got a 20% chance, 1 in 5 chance of dying. Right? Here's where they've tied one off with a balloon, very similar to how they take care of hemorrhoids. The etiology of these things, it's portal hypertension from something wrong with the liver. Excuse me. Usually liver disease, like cirrhosis of the liver, is a kind of a junk category. Um, there's several things that cause cirrhosis of the liver: alcoholism, viral hepatitis, autoimmune attack of the liver, hepatitis C and B. They can all make really hard to push blood through the liver, and that causes portal hypertension. Remember the hepatic portal vein, that can be backed up. Beaver dam in the liver, you can't get blood into the liver through the portal vein. Portal hypertension is in 90% of people with cirrhosis. Portal hypertension will also cause ascites. So there's the beaver inside the liver, and there's the portal, hepatic portal vein, and you can't get blood into it. We saw these in anatomy, right? The splenic vein, superior mesenteric vein, inferior mesenteric vein is variable, could come off any of these places. But there is a left gastric vein here. And coming off the left gastric vein is the portal esophageal vein. So you get a beaver dam here, all of these get backed up with water, including the one that goes to the esophagus, and it just backs up and blows up. Other causes of portal hypertension, schistosomiasis is actually the number one cause. It's a bug that gets in there. In developing nations, bug beaver dam, cancer of the liver, embolic disease, you get an embolism that gets stuck. That can do the trick. Anything that causes a beaver dam. Everything we said already. A beaver dam increases pressure. You can't get blood through the liver, so the pressure backs up and the veins start to stretch out. They're not very strong. They're not made to handle big pressure. There's just another picture of that setup. What are the clinical signs of esophageal varicosities? You're spitting up blood or you're vomiting up blood. It's going to irritate your stomach. So hematemesis, whether it be red or coffee ground vomitus, either one of those. It could go all the way through. Maybe it's a slow bleed and you have a tough stomach and you probably don't feel good, but you don't throw it up. But it starts coming out. You start getting black tarry stools at the other end. So it could come out as melanic stool or hematemesis. If one of those things bursts, it's the most common cause of death in patients with chronic portal hypertension from cirrhosis. So this kills people more than metastasis would occur. It's a very dangerous problem. And there's some more that they tied off, hoping to fix. Whew, that was a long one. All right, guys, this obviously didn't come out. It's not my fault this time. Something went down at the school because my internet, I have a chart of it right here. It was fine. Anyway, I'll put this on YouTube. See you later.